Dorothy had done everything right. She was 71, walked every morning before the neighborhood got noisy, took her blood pressure medication without fail, ate what her doctor told her to eat, and hadn't missed a grandchild's birthday in 11 years. But for the past 2 winters, and now most of this past spring, she had this feeling, not pain exactly, more like her head was wrapped in something damp and heavy, a drip in the back of her throat that woke her up at 3 in the morning, and a smell, or rather, the absence of one. Her daughter made pot roast on Sunday, and Dorothy stood over the stove and couldn't smell a thing. She went to her doctor, got antibiotics, felt better for about 10 days. Then it came back. She went again, more antibiotics, a decongestant spray, another 10 days of relief. Then it came back again. After the 4th round in 14 months, Dorothy's doctor referred her to a specialist, and what that specialist told her changed how she understood what had been happening in her body, not just for the past 2 winters, but possibly for years. I'm going to tell you what she learned, but first, I need to show you something that most people with chronic sinus problems, and honestly, some of the doctors treating them, haven't fully connected yet, because if your sinuses keep coming back after treatment, the reason is almost certainly not what you think it is. Here is the thing about chronic sinus problems that changes everything once you understand it. Most people think of sinusitis, sinus infection, sinus trouble, whatever they call it, as an infection that comes back, like a cold that keeps returning, and so the natural solution seems obvious. Treat the infection, kill the bacteria, take the antibiotic, feel better. But a 2023 clinical review published in American Family Physician, one of the most widely read medical journals for practicing physicians, described chronic rhinosinusitis as something fundamentally different, not primarily an infection, but an inflammatory disease. That distinction matters more than almost anything else in this video. Let me explain what that means inside your body, because once you see the mechanism, the reason it keeps coming back will make complete sense. Stage 1, the lining becomes inflamed. Your sinuses are lined with a thin layer of tissue, delicate, moist, designed to filter the air you breathe and move mucus toward your throat through tiny coordinated movements. Think of it like a slow, gentle conveyor belt, constantly clearing things out. When something irritates that lining, a virus, an allergen, smoke, dust, the tissue swells. That's normal. That's what's supposed to happen. The swelling is your immune system showing up to deal with the problem. The trouble begins when the swelling doesn't fully go away. In chronic rhinosinusitis, which is the medical term for the condition we're talking about today, and which I'll simply call chronic sinus disease, the lining stays inflamed. Not dramatically inflamed, not enough to give you a fever or knock you flat, just persistently, quietly swollen, overactive, running hotter than it should. Stage 2, the drain gets blocked. Your sinuses aren't solid spaces, they're hollow chambers, 4 pairs of them actually, connected to your nasal passages through small openings. Those openings are where mucus is supposed to drain out. When the lining swells, those openings narrow, sometimes they close almost entirely, and now the mucus that's constantly being produced has nowhere to go. Think of your kitchen sink, with a drain that's slowly being squeezed shut from the inside. The water doesn't stop coming, the faucet keeps running, but the exit gets tighter and tighter, until nothing moves the way it should. Mucus starts to pool, it gets thicker, it sits in spaces that are now warm, still, and dark, which happens to be an ideal environment for bacteria and other irritants to take hold. Stage 3, the cycle locks in. Here's where the mechanism becomes self-reinforcing, and this is the part that explains why Dorothy kept coming back to her doctor year after year. So please pay close attention here. The pooled mucus irritates the inflamed lining further. More swelling, narrower openings, more trapped mucus. The cycle feeds itself. A review published in the Journal of Allergy and Clinical Immunology in Practice described this as a self-sustaining inflammatory cycle, one that can continue running in the background long after the original trigger is gone. So when an antibiotic clears a bacterial flare-up, the infection may go away, but the swollen lining, still there, the cycle keeps running. It's because the underlying inflammation was never addressed, not because you caught a new infection. Why this hits harder after 60? Now here's what makes this specifically important for people in their 60s, 70s, and beyond. An NIH review focused specifically on older adults found that seniors often present with subtler symptoms: less facial pain, more vague congestion, fatigue, and throat drainage that gets dismissed as allergies. Because the signals are quieter, the disease goes unrecognized longer. By the time it's being evaluated seriously, the inflammation may have been running for years. There's also a second mechanism that shows up more often in older adults, and it dramatically changes how stubborn the condition becomes. The polyp factor. In some people, and this is more common in adults over 60 who also have asthma, the chronic inflammation produces something called nasal polyps. In plain language, they are small, soft growths that form in the sinus lining as a result of long-term type 2 inflammation, a specific kind of inflammatory response your immune system produces. These polyps physically narrow the drainage pathways, and they change the condition from something that can usually be managed with consistent daily treatment into something more stubborn, one that may require a different level of intervention entirely. The critical signal to watch for it is loss of smell. That is often the first sign that polyps are present, and it is a symptom that far too many people dismiss as just part of getting older. It isn't, and I'll come back to that in a moment. Now that you understand what is happening inside your body, the inflamed lining, the blocked drain, the self-reinforcing cycle, and how polyps can change the picture, here is what to actually do about it. I'm going to walk you through 7 things that drive chronic sinus disease in people over 60, what each one is, why it matters specifically for you, and what the evidence says about addressing it, and what you should do on your part in fighting this chronic challenge. These are not random tips. Each one connects directly to the mechanism I just described. And I'm starting with the one that stops most people cold, including some physicians who have reviewed this research. Item 1, you're treating the flare, not the fire. This is the one. Most people with chronic sinus disease spend years in the same cycle. Symptoms get bad enough to see a doctor. They get an antibiotic or a decongestant. They feel better. They stop treatment. The symptoms return and then repeat. The problem is that this approach treats the flare, the acute episode, while leaving the underlying fire completely unaddressed. The 2023 American Family Physician Review is direct about this. The primary driver in most chronic rhinosinusitis cases is not bacterial infection. It is sustained mucosal inflammation. And you probably know, inflammation does not respond to antibiotics. That means if your sinuses keep coming back after antibiotics, it is almost certainly not because you need a stronger antibiotic. It is because the antibiotic is the wrong tool for the core problem. You are bailing water out of a flooded basement without ever fixing the pipe. The shift that changes everything for you is moving from rescue treatment, that is, treating each flare as it arrives, to maintenance treatment that addresses the inflammation every single day, even when you feel fine. That shift is what the rest of this list is built around. Item 2, your daily saline rinse is not optional, and most people are doing it wrong. If there is one treatment in this entire video that is both widely underestimated and supported by strong clinical evidence, it is high-volume saline irrigation, what most people call a neti pot or a sinus rinse. A Cochrane review, one of the most rigorous forms of medical evidence, where researchers analyze all available studies on a treatment, found that regular saline irrigation significantly improves symptoms and quality of life in chronic rhinosinusitis. It is listed as a first-line recommendation in the AAFP Clinical Review and endorsed by the American Academy of Otolaryngology. Here is why it works. Mechanically, saline rinse physically washes inflammatory material, thickened mucus, and irritants out of the nasal passages. It keeps the drainage pathways clearer. It reduces the buildup. That keeps the inflammatory cycle going. But here is what most people get wrong. They do it during a bad flare, rinse for a week, feel better, stop, then the cycle starts again. Saline irrigation works as a maintenance tool, not a rescue tool, used once or twice daily. Even on days when symptoms are mild, it interrupts the buildup before it reaches the point of a full flare. 2 specific things matter for effectiveness in this. They are volume and consistency. A small spray bottle delivers a fraction of the irrigation that a full squeeze bottle or neti pot provides. The rinse needs to reach the deeper nasal passages to clear what needs clearing, and it needs to happen every day, not just on the bad ones. If you have ever tried this and felt like it didn't help much, the most likely reason is that you used it only when things were already bad, or you stopped too soon. Item 3, the intranasal steroid spray your doctor mentioned, is more powerful than you think. Remember Dorothy, her grip on smell fatting, her cycles of brief relief followed by return? Item 3 is directly connected to what was happening to her, so type in the comments that you are here from starting. Intranasal corticosteroid sprays, the kind available both by prescription and increasingly over the counter, work by reducing the underlying swelling in the sinus lining, not suppressing your immune system, not flooding your body with steroids, delivering a very small amount of anti-inflammatory medication directly to the tissue. That is driving the cycle. A 2025 review published in the Journal of Allergy and Clinical Immunology in Practice confirmed their effectiveness across multiple patient populations, including older adults. Here is what most people do wrong with these sprays. They use them the same way they use saline, reactively, during bad periods, then stopping when things improve. These sprays require 4 to 6 weeks of consistent daily use before their full effect develops. The inflammation they are treating did not appear overnight. It cannot be reversed overnight either. There is also a technique issue here, where most people miss. The spray needs to reach the upper nasal passages to be effective. Most people tilt their head back, which actually sends the medication toward the throat rather than the sinuses. The correct technique is to aim slightly toward the outer wall of the nose, toward the ear on the same side, with the head slightly forward. Used correctly and consistently, intranasal steroids combined with daily saline irrigation represent what the clinical literature describes as the foundation of chronic rhinosinusitis management. I want to pause here for a second. If you have been using a saline rinse or a steroid spray only when things get bad, and stopping as soon as you feel better, type yes in the comments, because I want to show you exactly what that pattern costs you, and why the next item changes the equation entirely. Item 4, smell loss is not a minor symptom, it is a signal. This one is the item most people overlook, and in people over 60, it is one of the most important warning signs on this entire list. Loss or reduction of smell, the medical term is hyposmia, or in complete cases, anosmia, is frequently dismissed as a side effect of congestion. Blocked nose, can't smell, clear the congestion, smell comes back. But in chronic sinus disease, particularly in older adults, persistent smell loss often signals something more specific: the presence of nasal polyps, or a degree of inflammatory involvement that goes deeper than standard surface-level treatment reaches. The NIH review on chronic rhinosinusitis in elderly patients specifically flags smell loss as an under-recognized marker of more significant disease in older adults, one that should prompt evaluation, rather than reassurance. Practical test for you: if your sense of smell has been gradually fading, if food tastes less vivid, if you notice you're relying more on texture than flavor, if your morning coffee doesn't smell the way it used to, that is not just an inconvenience. That is your body signaling that the inflammation may have reached a level that warrants a closer look. This is a question to bring to your physician specifically. Could my smell loss be connected to my sinus disease? And does it suggest I should be evaluated for polyps? Item 5. Allergies and asthma may be quietly running the cycle. Here is something that surprises many people in a significant number of chronic sinus cases. The inflammation driving the cycle is not primarily coming from the sinuses themselves. It is coming from allergic inflammation in the nasal passages, or from asthma, that continuously re-triggers the sinus lining. The AAFP review notes that allergic rhinitis and asthma are among the most common overlapping conditions in chronic rhinosinusitis patients, and in adults over 60. These overlaps are frequently under-identified. Allergies in older adults often present differently than in younger people. Less sneezing, more persistent congestion, more fatigue. If your sinus disease keeps returning despite consistent saline and steroid use, and especially if you notice that certain seasons, environments, or exposures make things worse, the question worth asking your physician is whether underlying allergy or asthma is functioning as a continuous trigger that is refueling the inflammatory cycle. The practical implication: treating only the sinuses while leaving an active allergic or asthmatic driver unaddressed, is like mopping the floor while the faucet is still running. Item 6. If symptoms are one-sided or consistently fail treatment, anatomy may be part of the problem. Most chronic sinus disease is bilateral, both sides of the nasal passages involved, symptoms that shift and move, but when symptoms are consistently worse, or exclusively on one side, or when someone has done everything right with saline, steroids, and allergy management, and still cannot get control, structural anatomy deserves evaluation. A deviated nasal septum, for example, is an anatomical condition where the wall that divides the two sides of your nose is shifted to one side. This can physically narrow one drainage pathway enough that the inflammatory cycle on that side becomes self-sustaining, regardless of how well the inflammation is medically managed. The AAFP Sinusitis Guideline recommends nasal endoscopy and CT imaging when symptoms persist despite appropriate medical therapy, not as a first step, but as a crucial diagnostic step when the medical approach is not working. The key point for this item is, if you have been told your sinuses look fine and your treatment seems adequate, but nothing is changing, a structural evaluation may reveal something that medication alone cannot fix. Item 7. Surgery does not cure the tendency, but it can change the trajectory. This is the item most people either fear unnecessarily or expect too much from, and both misunderstandings lead to poor outcomes. Endoscopic sinus surgery, the most common surgical approach for chronic rhinosinusitis, works by widening the natural drainage openings of the sinuses. It removes tissue that is blocking drainage, and in cases with polyps, removes polyp tissue that has physically obstructed the passages. What it does not do is remove the underlying tendency toward inflammation. The AAFP review and the PMC review on chronic rhinosinusitis management are both explicit on this point. Surgery improves the anatomy and creates better conditions for medication to work, but the inflammation that drove the disease is still present afterward. Patients who do best after surgery are those who continue consistent maintenance treatment, saline, intranasal steroids, and management of any overlapping conditions afterward. Surgery, when it is the right call, is not the end of the story, it is a reset. That gives your maintenance treatment a better chance of working. Patients who go into surgery expecting a permanent cure and then stop all maintenance treatment almost always see the disease return. Number 7 is the one most people don't ask their doctor about, and it may be the piece that has been missing from every treatment plan that only worked halfway. Before I close today's video, I want to give you something concrete to take into your next appointment. Because here is the reality. A standard follow-up with a primary care physician for sinus problems often lasts less than 15 minutes. In that time, a doctor is managing your chart, your medications, your other conditions, and whatever brought you in that day. Chronic sinus disease, the kind that keeps coming back, the kind that has been quietly running for years, rarely gets the focused conversation it deserves in that window. These 5 questions are designed to change that. They are not challenges to your physician. They are tools that help your doctor help you more specifically. Bring them written down. Ask them in order. The answers will tell you a great deal about whether your current treatment plan is actually targeting the right problem. Question 1. Is my sinus disease primarily inflammatory, or is there evidence of active infection driving my symptoms? Why it matters. This question gets directly at the mechanism we covered today. If your physician confirms that the primary driver is inflammation, not active bacterial infection, then the conversation about antibiotics shifts. You are not trying to avoid necessary treatment. You are trying to make sure the treatment matches the actual problem. What a good answer sounds like. Based on your symptoms and history, it appears the main issue is chronic inflammation rather than repeated acute infections. Here's what that means for your treatment plan. If your physician pauses at this question, or hasn't previously framed your condition this way, that pause itself is useful information. Question 2. Have I ever been evaluated for nasal polyps, and given my symptoms, especially my smell changes, should I be? Why it matters. As we covered, polyps change both the nature of the disease and the effectiveness of standard treatments. They are more common in people over 60 with persistent disease and any degree of asthma, and they are frequently not investigated until symptoms have been present for years. Smell loss specifically, is the clinical signal that warrants this question. If you have noticed any reduction in your sense of smell, even gradual, even subtle, this question is not optional. What a good answer sounds like. You haven't been formally evaluated for polyps. Given your symptoms, I'd like to either look directly with a scope or refer you to an ENT specialist for that evaluation. If your physician says, you probably don't have polyps without having looked, that is a conversation worth continuing. Question 3. Could underlying allergies or asthma be contributing to why my sinus symptoms keep returning? Why it matters. The AAFP clinical review identifies allergic rhinitis and asthma as among the most common conditions driving the inflammatory cycle in chronic sinusitis. And in people over 60, both are frequently underdiagnosed. You may have a significant allergic contribution to your sinus disease that has never been formally tested. What a good answer sounds like. That's a reasonable question given your pattern. Let's either do some allergy testing or consider a referral to an allergist to see if there's an underlying trigger we haven't addressed. If you have never been allergy tested and your sinus disease keeps returning despite treatment, this question may open a door that changes your entire management plan afterwards. Question 4. Am I using my saline rinse and intranasal steroid spray correctly and consistently enough for them to actually work? Why it matters. Technique and consistency are the two most common reasons these treatments underperform. As we covered, the spray needs to be aimed correctly to reach the right tissue. The rinse needs to be high volume and daily, not just during flares. Many people have been told to use these treatments without being shown specifically how. What a good answer sounds like. Your physician or a nurse practitioner demonstrates the correct technique and confirms the expected timeline. That intranasal steroids typically require 4 to 6 weeks of consistent use before full effect. If you leave an appointment with a prescription for an intranasal steroid and no one has discussed technique or timeline, ask before you leave the office. Question 5. At what point would you recommend CT imaging, nasal endoscopy, or a referral to an ENT specialist? And are we at that point now? Why it matters. The AAFP sinusitis guideline recommends imaging and specialist referral when symptoms persist despite appropriate medical management. Appropriate medical management means consistent saline plus intranasal steroids, with allergy evaluation if indicated, not just a round of antibiotics. What a good answer sounds like. Given how long your symptoms have persisted and how they've responded to treatment so far, I think it's time to refer you to an ENT for a more thorough evaluation, including the possibility of imaging. If you have been symptomatic for more than 3 months and have not had either imaging or specialist evaluation, this question is the one most likely to move your care forward in a meaningful way. At the beginning of this video, I told you about Dorothy, her 4 rounds of antibiotics in 14 months, the pot roast she couldn't smell, the Sunday dinners she stopped hosting. Now you know exactly what was happening to her and why the antibiotics kept failing. Not because they were the wrong antibiotic, because the core problem was never an infection to begin with. It was an inflammatory cycle that had been running for years, quietly, in the background, narrowing her drainage pathways and building the conditions for polyps to form. I also told you that there was something about her kitchen cabinet that no one had connected. That was the dust mite sensitivity present in her bedding, her upholstered furniture, the environments she spent the most time in, quietly refueling her baseline inflammation every single day, while every treatment addressed only the symptoms it produced. The cycle wasn't inevitable, it was just unrecognized, and that is exactly the situation this video was designed to change for you. Here are the 4 key takeaways from today's video. First, chronic sinus disease is primarily an inflammatory condition, not a recurring infection. Antibiotics treat flares, they do not address the underlying cycle. The goal is maintenance, not rescue. Second, daily saline irrigation and consistent intranasal corticosteroid spray, used correctly and every day, not just during bad periods, are the foundation of management and are supported by the strongest available clinical evidence. Third, smell loss is not a minor symptom to monitor. It is a signal that warrants evaluation for nasal polyps, and it should prompt a direct conversation with your physician. Fourth, if your sinus disease keeps returning despite doing everything right, Allergy and asthma overlap deserves investigation. An untreated allergic trigger can continuously reignite the inflammatory cycle, regardless of what else you do. I have 2 questions for you today. First, have you ever experienced the cycle we talked about in this video? Brief relief, then the symptoms returning. And how long has that been going on for you? Tell me in the comments. And tell me your age. I ask because the pattern is different across different age groups, and I want to understand what people watching this are actually living with. Second, which item on today's list was the one you hadn't heard before? Type just the number. I want to know which piece of this is most missing from the conversations people are having with their doctors, because that tells me exactly what to cover next. Tomorrow I'm covering something that affects a significant number of people over 60, who are currently taking the most commonly prescribed medications for blood pressure and heart conditions, and almost no one has connected it to the sleep and energy problems they've been experiencing for years. It is not a drug interaction warning. It is something more specific than that, and more actionable. If you want to make sure you see it, make sure you're subscribed, because that connection, once you understand it, is not something you'll want to have missed. Every video on this channel covers one thing your doctor genuinely wants to help you with, but rarely has 15 uninterrupted minutes to explain. That's what this channel is for. If you watch to the end today, you now understand something about your sinus disease that most people, including some of the physicians prescribing antibiotics for it, haven't fully connected yet. Dorothy figured it out at 71. It changed her Sunday mornings. I'll see you tomorrow.